Hi, this video is to highlight and maybe give some ideas about oxygen management for COVID patients. It's been a disaster. This epidemic showed how inflexible American intensivists are, and we all fell for the trap that the CDC put for us. We had learned as we go during this epidemic. I wanted to share what we learned here in our hospital, and I wanted to share to share many ideas that I not all of them are mine, but got from many other people. So basically, you had the patient coming in COVID-19 positive or at least suspicious of COVID-19. And what you do is that initially, we're gonna just use, as usual, we'll give the 6-liter nasal cannula. This is the typical nasal cannula, 6 liters per minute. Put it in the patient's nose. Why do we have 6 liters? Why is the max on this nasal cannula 6 liters in general for any patient? Because of sinusitis and headache. You can't give more than this because the patient is going to have sinusitis and headache. So now this patient has a 6-liter nasal cannula, and basically there's at this level there's no aerosolization, there's no or at least minimal aerosolization to the point that you can be 6 feet away from the patient without mask. Obviously you're not going to do that, and you're not going to have there's a minimal risk, but obviously we're all wearing N95 in these situations, and we're probably in a negative pressure room. But as far as safety, 6 liters per minute, everybody agrees that it's safe. There's no aerosolization. Now, one of the biggest disasters that happened is that when the CDC recommended initially against the use of a high flow nasal cannula, they did not differentiate between which high flow we're talking about. Most hospitals, if you ask them what is the high flow nasal cannula, they're going to tell you, we mean the nasal cannula that can reach up to, that is heated and humidified, and can reach up to 70 liters per minute, 70 liters per minute, right? Nobody talks about this. Nobody means by high flow this. In certain hospitals, we have this nasal cannula that can reach up to 15 liters per minute, but not to 70 liters per minute. This is a little bit bigger nasal cannula. It should go, it's actually designed to go through an aqua pack, right, to humidify. And when it's humidified, it allows the patient to tolerate up to 15 liters on the nasal cannula. And it's humidified, so it doesn't really cause the sinusitis and the headache. And if the patient is still desaturating on the 6-liter nasal cannula, please don't intubate the patient. We don't have enough vents even to do that. And it becomes, what happened and what we've seen happen, it becomes like a self-fulfilling hypothesis. People are saying, COVID-19, oh my God, it's a very, very bad, it's a very extreme lung injury, which it is. It is a severe lung injury, but we've seen lung injuries like this before from influenza and from other gram-negative sepsis and from pneumonia, ARDS, all of these things. So it's not unheard of, but it becomes a self-fulfilling hypothesis, because when a patient comes to the hospital based on the CDC recommendation, we should not give high-flow nasal cannula, which people lumped this with the high-flow nasal cannula that is 70 liters, so they don't use it. Number two, they don't use Bipap, obviously, because it will disperse the droplets. And they don't use high-flow, heated wire high-flow nasal cannula, which is the bigger high-flow nasal cannula that can give up to 70 liters. So if you don't use nebs, and you use only inhalers, which probably gonna end up in the patient's mouth, never gonna go beyond that. So by using all of this, what ends up happening at the end is that it becomes a self-fulfilling hypothesis. Everybody say, wow, they go to the floor for 3 days and then they crash and come to the ICU to be intubated. Well, of course, if you're not treating the patient, there's no treatment for COVID-19. And hydroxychloroquine and azithro, this is all anti-inflammatory stuff. not a perfect treatment for the disease, and we don't know if it really treats the disease or not. We do give it, but we don't know if it treats the disease or not. So, in any case, these patients arrive on the floor, they stay there for 3 days and crash. And then we intubate them. And then we can't extubate them because in order to extubate them, you have to extubate them to 6-liter nasal cannula or even 15-liter nasal cannula, which is sometimes very difficult. You know? So I feel like our hands or feet were chopped at the beginning of this epidemic because we can't do our job in ideal way because there's a lot of limitation, and I understand where it's coming from because obviously protection of the staff is #1 priority because they are the one that's going to treat the next patient, but also we have to use our heads a little bit. So if you think about it, if I give somebody 15-liter nasal cannula, aquapack here, it doesn't matter really, it's just you're bubbling here, there's no aerosolization by the patient here. Normal human beings, when we breathe, we create like negative, we have a flow of about maybe 10 liters per minute or up to maybe 20 liters per minute, especially if we're in a little bit of respiratory distress. But 10 to 20 liters per minute, normal breathing. When you give somebody 15 liters per minute, chances are the amount of aerosolization around the patient is not going to be too much because the whole 15 milliliter per minute is going to be probably used for inspiration every time. So there's not going to be a lot of excess oxygen around the patient and droplets spreading all over the place for 15 liters. So from the beginning, we actually approved the use of 15-liter nasal cannula without any issues. If you have any doubts, you can put a surgical mask on the patient. If you put a surgical mask, then chances are you're not going to have significant droplets all over the place. Now, if the patient fails this, what are we going to do? We can't just go and intubate the patient. Now, finally, after a while, everybody realized that we were intubating too much in the beginning of this epidemic, and I agree. We have to use our heads, so we can use this. This is a 30 French nasal airway. I would recommend using 30 French for adult males and 28 for adult females. It's small enough, you can even use 28 for adult males. It doesn't have to be the typical 36 or 34 French, which opens the airway. This one we just need to put it so it reaches to the oropharynx. And then we use the old nasal cannula, the other one that is that gives you 6 liters per minute, and we just cut it, right? And as I'm doing this, I probably want to give credit for Kathy Carlson and Julie Demani and also Dr. No and Dr. Nair. We all worked on a nice protocol for the hospital. So as you see, I cut the nasal cannula, and you can see here that the part that has the 2 prongs, I just made a knot, and then you pull the knot like this, so no flow is going to go through this limb. Okay, this is an obsolete limb now. This is the limb that the flow will go through. Now I put that through the nasal airway until it just peaks here. Right? Until it's just peaking here. And don't extend it beyond it because you really don't want to irritate the patient. And then right here on top, just for extra protection, right? This is peaking here, right here. For extra protection, Tegaderm. You put the Tegaderm on top of the whole situation here. Everything will be covered. So now, no oxygen, nothing is going to come out from here. Now, this is the apparatus. This is how it looks like now. This limb is completely obsolete now, and this limb is inside the nasal airway and completely sealed with a tegaderm. Now we lubricate and gently put it into the patient nose, as usual. Take this out, right? And then we put it inside the patient's nose. And then, so this failed, right? This 15-liter nasal cannula is not enough for the patient. This one is insufflating way deep into the patient's throat. I can go more than 15 liter. And as you know, this is the flow meter that has a Thorpe tube inside. The Thorpe tube is a graduated tube that gets bigger and bigger as you go up, and then it flays open completely at the top. So this ball that floats here, it floats at 4-liter nasal cannula when the width is this much. If you go, the bigger width, you need 15-liter nasal cannula, 15-liter of flow to keep it floating. But if you go, this is what it sounds at 15-liter. If you go above 15-liter, this is what it sounds. And it actually, if you read there, it's written flood. Some call it flood, some call it flush, and some that call it nothing, and they don't say anything. But whatever, when you hear that sound, that means you're going above 15 liters per minute. You can go like this, or you can go even higher, right? The maximum is 150 liters per minute, but also you can do kind of lower, which is anything between 15 liters and 150 liters per minute, and titrated for the patient's oxygenation. So that's the whole point, is that you can insufflate here inside the patient's mouth, which in the oropharynx or even in the hypopharynx, in the oropharynx usually, and that will allow the patient to have the whole mouth is going to be filled with oxygen, and it's going to be, and some of it will be coming out actually of the patient. If you put a surgical mask on top of them like this, that'll be perfect, almost perfect. There'll be no aerosolization. This can be used even on the floor in cases of the surge. That you can't take a patient like this to the unit, and you don't want to temporize them on the floor until you have a vent for them, or you want to avoid the vent altogether. This will prevent aerosolization outside of the normal aerosolization that happens if you walk into a room that has an awake, spontaneously breathing COVID-19 patient. This will be no more than that, or minimally more than that, right? So this will save lots of lives. Many lives will be saved with this device here. Okay, now let's say this device failed, and whether the patient is not tolerating it, or has a bleeding problems that you can't put it inside, or one thing or the other. Or maybe need more. That's another problem that happened during this epidemic, thanks to our CDC. The CPAP. Nobody said that the CPAP is different than BiPAP, but if you think about it, CPAP is completely different than BiPAP when it comes to droplets, right? So if you think about it, if I'm spontaneously breathing COVID-19 patient and you walk into the door, obviously wearing your full PPE, and you have a negative pressure room. If I cough in your face, you're at more risk this way. If I breathe fast or breathe deep, in and out in your face, you're at more risk. But if you have a CPAP mask on you here, this CPAP mask on the patient, the chances of me actually like coughing so far out, it's much lower, because the path of least resistance is for the air coming out of the patient to go into the tubing. That's the path of least resistance. There's also some air that will come out from leakage of the mask, and some air will come out from the holes in the mask, like the kind of the release valve in the mask itself for forceful exhalation. But all of that would be hindered by a CPAP. When you have a CPAP pressure, we usually start with 10. If you put somebody on 10 of CPAP, that can actually hinder the amount of spread of droplets. So if you think about the BiPAP, I agree. BiPAP does make a big amount of spread of the droplets and could be dangerous for the staff. But CDC should have told us. They should have told us that the CPAP is different than BiPAP, right? So people can think about that to temporize patients before so they can avoid intubations in older individuals and DNR and DNI patients and all of these things. So the CPAP is different. If you think about the BiPAP, what is the force that disperses the droplets? The force that disperses the droplets is not the exhalation force. The exhalation force, as I said before, the air is going to go into the tubing, maybe a little bit come out from here and maybe a little bit come out from the holes in the mask. But the force that actually disperses it is the force that are coming at 40 to 60 liters per minute, or maybe more, coming in from the BiPAP. That's the inspiratory force. Now the mask is full of droplets, full of COVID-19. The next force that comes in will disperse, the droplets potentially outside the mask, potentially coming out from the leaks around the mask, and that's what kind of is the different force. Because if you think about it, what's the difference between somebody who's spontaneously breathing and exhaling in front of you versus somebody who's exhaling into a mask? Of course, into the mask is better. So the force that the CDC is recommending against or warning people from is the force that actually pushes air in a very high pressure that can actually leak this way, or if it comes out or something, it will leak completely. So that's why we consider the CPAP not as dangerous or not as dispersing of the droplets as BiPAP, and can be used without any extra precautions other than full PPE and a negative pressure room. But it can be used for in a negative pressure room with the staff wearing full PPE, so that will save the patient, right? Now, if that fails, then the next step is the heated wire high flow nasal cannula. I like to make the distinction between high flow nasal cannula and heated wire high flow nasal cannula. The heated wire high flow nasal cannula, that's what the CDC meant when they said don't use high flow nasal cannula. All right? We talked about that before when we talked about this is the high flow nasal cannula. The other one, that's 15 liters, and the other one is a 70-liter nasal cannula. I don't have it here, but it's actually, this is the heated wire high flow nasal cannula. The heated wire high flow nasal cannula what it does, it gives you 70 liters of oxygen, up to 70 liters of 100% oxygen that fills the nose, fills the nasopharynx, fills the oropharynx, fills the mouth, comes out of the mouth, and make a halo of oxygen around the patient, right? And this halo of oxygen, basically anywhere you breathe from, if you breathe from your ears, you're gonna get 100% oxygen. That's the whole point of 70 liters, because it's beyond what the normal breathing is, which is 10 to 20 liters per minute. So when you use the heated wire high flow nasal cannula, that is recommended against by the CDC, and I agree. You should not use a heated wire high flow nasal cannula, even if you're wearing full PPE and in a negative pressure room, because the negative pressure is not helping me if if I'm sitting next to the patient doing stuff with them and the things are coming in my face, right? Sticking to my hair and skin and all of these things. So that's fine. But let's be a little bit more flexible. The system is not flexible in here, and that's why we're having all of these disasters. The system is not flexible. So instead of people saying, what can we do to do this? So there's two scenarios for the heated wire high flow. And then after the heated wire high flow, if the patient fails, you need to put the patient on BiPAP, which is also recommended against by the CDC. These are the steps before intubation. So I'm talking now about these two steps, the heated wire high flow and the BiPAP. And by the way, there's a device that ambulances use, which is a very cheap BiPAP mask, if you will, and that goes just directly to the flow meter and pressurized as a CPAP, basically. also, so that can be used also in cases if you run out of vents. But in general, the Bipap and the heated wire high flow, that's a big dilemma now. These are the hands and feet that were chopped off in the beginning of this epidemic until we finally found a solution for it. Now, there is a study that is published, very nice study that is pre-publication in CHEST, that actually showed that even at 40 liters per minute heated wire high flow, not this one, the heated wire high flow, if you put a surgical mask on a patient, which it's fine, I can put a surgical mask on the patient. They actually showed using thermal energy and stuff like that. They found that there's no flow outside the confines of the mask, no droplets. So it can be used safely, right? If there's still apprehension, I would put, instead of the surgical mask, I would put a non-rebreather mask, but inactive. Inactive non-rebreather goes in, and that actually will be nice because it will accumulate more of the, and it's more sealed than a surgical mask, and it's more clear, so the patient you can see his mouth and what's happening if he's vomiting or something like this. So that's actually better than a surgical mask. So that's another, if you have more flexibility in your hospital and you can convince the staff, don't worry, the study showed against what the CDC recommended, okay? But the Bipap's still a problem, okay? It will leak all over the place, right? Some people say, oh, can you put a surgical mask on the Bipap? You can. You can put even another breather on the Bipap, right? You can do any of this stuff, but again, the staff is gonna read online, they're gonna start saying, oh my God, the hospital is subjecting us to this or subjecting us to that, right? So we came up with a simple solution here. We got this. This is like a bed rack or a bed cage, if you will. It's used typically for vascular surgery, or when they have ulcers in the foot, and you put it at it goes under the mattress in the lower part of the bed to protect the foot from the sheets, right? So when the sheets go over like this and the foot can rest underneath that. So we took that and we put it underneath here. So it goes, the small part of it goes underneath here. And it does go deep like this, that you can actually even put the rails up, and it goes like that. And then we got, this is the best design, I think, the sterile Z sheet from the OR. This is a sheet that they use to cover big cables in the OR. It's a sterile sheet actually, but you can use, I'm going to tell you some other options, but this is what we used here. And we go and we put this sheet like this. Right? We put this sheet like this. It actually it's long enough that will cover the whole patient. And it's wide from the sides too. Covers the whole patient. All the way. You can see the whole bed is covered. We don't need to cover the whole bed, we only need to cover till here. Right? And then with a little bit of tape, we just tape it to the head of the bed. Right? Anywhere, you just tape it. Just so it doesn't move. And then you can pass the Bipap from here, or and put it like this and cover it like this, or pass the heated wire, high flow nasal cannula, or whatever these two things that typically are not used because of the how much droplets they create, and it's so flexible. The patient is, as you can see the patient's face. You can see that. There's a distance between the patient and this, and the patient's tolerated very well. We've done it on a few patients. You can even sit the patient up, and this thing nothing happens to it because it goes under the mattress, so it doesn't fall. We thought about using the plexiglass boxes for intubation, but they fall. right? Unless it goes under the mattress. That's another design you can make, right? And it goes like this. So you can sit the patient up, put the BiPAP on them, and do like this. And staff can actually do most of the intervention like this. Go from here and here. Sometimes if I want to change the BiPAP to a heated wire, high flow or something, I take the BiPAP off. Somebody's helping me from the other side. I just go like this to move the BiPAP, decreases the amount. Obviously, I'm wearing still all the PPEs, but there's no direct, or very minimal direct exposure to droplets here. The droplets will stick to the lower part to the inner part of this sheet, but it's not going to be in the air, so you can inhale it. And of course, the sheet can be either cleaned or thrown out. These sheets are disposable, so it should be thrown out. The first time we actually use a shower curtain. You can use a shower curtain, because that's what we reached to in the United States of America, that everybody's trying to improvise to help our patients. There's other designs for it. For example, you can have two. You don't have to have those that are hanging from the ceiling, but you can have just any regular two IV poles. Right? This one can be removed as if you don't have it. And let's assume your hospital doesn't have this. And we can just tape one of those here, or put one of those here, right? And from the other side, we can also do the same. That's easier because most hospitals will just have IV poles. You don't have to have the bed rack or whatever, right? Like this. And from behind, that's here you are. Like this. From behind, you can have the same thing. So you can have another. This is like the old pediatric group tent. We're gonna call this the COVID tent, right? The Brockton Covid tent. We just put this, and we go from the back, and you can put the head down or put the head up. It really doesn't matter. We actually did that on patients who are sitting in a chair. So you want somebody like this, you want to sit them in the chair and do BiPAP, you can sit in a chair and you can have from both sides like this, and it also like kind of closed a little bit here, and this way there's not a lot of active droplet dispersing when you do the heated wire high flow or the BiPAP. So I really feel like after having my hands and feet chopped off in the beginning of this epidemic, I feel like I grew them back. So now I can treat my patients. It's a severe illness, severe inflammation, severe ARDS that actually, from what we've seen, there's no severe hypoxia, but it's just lingering hypoxia. It's severe hypoxia, but not to the point of dying from hypoxia. In my experience, we can temporize anybody basically, but we have to. But really, it takes a long time to extubate these people. So anything that you can do to prevent intubation, or anything that you can do to shorten intubation, so you can extubate them early, that will be the best thing to do. One last advice here is that enough with the volume control, please. Enough with the volume control. We have to be a little bit more flexible than this. There is evidence of APRV trumping volume control in all aspects. Improved, decreased days on the vent, decreased trachs, and also improved mortality. The first two were statistically significant from a study that was done in China, by the way, before that epidemic. And the third parameter, which is mortality, it showed p-value of 0.053. So it still showed extreme improvement when you put the patient on APRV or bi-level, as opposed to low total volume ventilation, which came out more than 20 years ago. It's time for us to move. Time in the United States to start moving and actually kind of be flexible and think outside the box. If you put the patient on volume control, this is sad to say that people who put the patients on volume control, that's why you have emergency prone positioning. Because there's nothing you can do. You gotta put them on 6 milliliter per kilogram tidal volume, they're done. You know, the hypoxia is so severe that you're just calling everybody for a stat prone position, right? I'm not saying I love prone position. Prone position is great, but we find that when we put our patients on APRV or bi-level, they do much better. And by definition, they don't need to be prone. Let's be real here. We can't prone everybody, right? It's very labor intensive and it has its own complication. So we have to be selective which one we prone. So in an epidemic like this, if you have 150 patients in your ICU and you use, you know, on the floors and in the tents and everything, if you have 150 patients and you're using nurses that never did ICU before because you're using everybody, you can't just say, okay, let's prone 100 of them. You know, that doesn't make any sense. You're gonna have to be very selective. APRV, it's a limited pressure, it recruits much better, and it's a weaning mode, and it's actually a mode that decreases the need for sedation, and it's also a mode that you know, basically show you the mechanics of the lung, that you can actually find out what the mechanics of the lungs are, and also it's a mode of ventilation that decreases days on the vent and improve mortality. So that's the best thing that you can do for your patients. So I think this protocol, I'm comfortable with it, we're comfortable with it, and we wanted to share it so this way people can benefit from it if it applies. And thank you.